Hello, and thank you for joining this OncLive TV peer exchange, an expert-based discussion of the multidisciplinary perspective on differentiated thyroid cancer. Although most patients with differentiated thyroid cancer have an excellent prognosis, a subset of these patients will develop a more aggressive refractory phenotype. Fortunately, recent understanding of the molecular pathogenesis of thyroid cancer has led to exciting novel therapies for this advanced disease. In this discussion, my colleagues and I will provide a perspective on the latest information about how to use these therapies and the path forward to a more personalized approach for patients. My name is Dr. Michael Tuttle, and I'm a professor of medicine for the endocrinology service at Memorial Sloan Kettering Cancer Center. Participating today on our distinguished panel are Dr. Marcia Brose, an associate professor at the University of Pennsylvania in Philadelphia, and the director of Center for Rare Cancers and Personalized Therapy. Dr. Naifa Busaidy, an associate professor at the University of Texas MD Anderson Cancer Center and director of the Thyroid Nodule Clinic. Dr. Eric Sherman, an associate professor of medicine at Memorial Sloan Kettering Cancer Center and Head and Neck Division of Solid Tumor Service. And Dr. Frank Worden, a professor of medicine at the University of Michigan Comprehensive Cancer Center. Thank you again for joining us, and let's begin. In our first section, we're going to talk about sort of that initial diagnosis and staging and risk assessment. Dr. Busaidy, just take me from the beginning. What's the typical presentation of a patient that gets diagnosed with thyroid cancer? What's their sort of initial workup look like for the average patient?
Sure. So most patients with thyroid cancer have their thyroid cancer incidentally found. Most of these patients are asymptomatic and don't have any symptoms. So they start off, either they went to a health fair and had a carotid ultrasound and they happen to have a thyroid nodule found, so then they see their physician and get an ultrasound of their neck. A full evaluation of the entire neck is important. You start out looking at the thyroid and you look at the nodules, and very often up to 65% of the population can have nodules on their thyroid found on ultrasound. So it's important that we try and evaluate which of these nodules should be biopsied. So the first thing you do is the ultrasound, and you also get a blood test as a TSH. And what one is looking for is if the TSH is suppressed, then it suggests that the patient may be hyperthyroid. So one may then do a radioactive iodine, a I-123 or thyroid uptake scan to evaluate if the nodule is hot or not. And if the nodule is found to be hot, the risk of that nodule being malignant is less than 1%. So that may be a nodule you choose not to biopsy. It's a very rare instance where a hot nodule is truly thyroid cancer. So if your TSH is normal or high, you don't need the iodine scan. So what one would do is do the ultrasound and evaluate the characteristics of the nodule. And that's one of the biggest things that's changed in the guidelines lately, is that there's much more emphasis on don't just biopsy any nodule or the dominant nodule or the large nodule, but the nodules that are actually suspicious looking. So one may begin with a nodule that is greater than 1 or 1.5 centimeters that has suspicious sonographic characteristics and biopsy those nodules. And at the same time, one would look at the lymph nodes of the neck at the same time. If there's any lymph nodes that may be suspicious, those may need biopsying as well. Once the FNA is done, then one needs to look at the cytopathology of those nodules and evaluate whether it's malignant or not, and go down that pathway.
And in most of the patients, once they're diagnosed with thyroid cancer, they want to be reassured and be told that things are going to be okay. What are the sort of features that when you're doing this initial evaluation, do you find very reassuring? And then we'll come back in a minute and ask Frank to say, what are the features that you find really worrisome? So
Sure.
The reassuring things, what are the features that you're going to tell the patient you're probably going to do okay with the appropriate treatment?
Sure. So there's certain risk factors when we evaluate the patient as to how overall their prognosis or how they're going to do from a thyroid cancer standpoint from both death and recurrence. And if a patient's age they're young, under the age of 45, that age may be changing as we relook at the data. But for now, if the patient's under 45, if they're female, If they just have, if the nodule is small, especially smaller than 4 centimeters, and there's no lymph nodes that are seen on imaging preoperatively, and we'll get to surgery later, then those are reassuring things, that this is a patient who's going to do well with simple therapy.
So most of the patients we see are that sort of lowish risk, kind of small, confined to the thyroid. Frank, when you hear about the story of these presentation of thyroid cancers, what are some of the things that make you say, boy, this really makes me worry? This is a patient that may actually end up needing more than just surgery and radioactive iodine.
Right. So kind of counter to what Naifa was saying, we would worry about patients who are older, patients who are male, more so than the female patients. The patients have larger tumors, so those greater than 4 centimeters are those tumors that extend through the thyroid capsule. So that extension of the thyroid, or tumor through the thyroid capsule, is concerning. Patients who have bulky or large cervical or other neck lymph nodes and can extend down into the mediastinum, those are all concerning. In addition, patients can present with metastatic disease, and so those would be the patients we'd be concerned about for the highest risk of spread.
So, Marcia, Naifa talked largely about our initial staging, really revolving around the ultrasound. Are there certain features of that initial presentation that should warn us that maybe we need more staging, just the ultrasound? CTs or looking for distant metastasis? When do you think we should look outside the neck?
Well, it sounds like, I mean, I think the ATA guidelines are probably going to be more carefully elucidating this than I can off the top of my head. But I really do worry about patients who have the extrathyroidal extension or lymph nodes that actually extends outside of the lymph nodes. These are all people that are going to be at much higher risk, and they definitely should have additional staging, usually a CAT scan of the chest, remembering that these patients are going to get radioactive iodine, so when you do those stagings, you always do a non-contrast CT.
Yeah. So, Naifa, where do you draw the line? I mean, we talked a lot about using ultrasound as our initial staging. When do we say we need to go that extra step? I mean, you don't always do it. Probably most of the time we don't. But when are you thinking about that early in this initial staging and presentation?
So I think, all these patients, well, not all these patients, most of these patients are going to undergo surgery, either lobectomy or total thyroidectomy. So there's a couple of things that help us out. One is looking at the operative report and what the surgeon, having that conversation with the surgeon as to identifying what they saw intraoperatively. Was the thyroid cancer stuck on other organs in the neck? Were there lateral lymph nodes that were large? Were there multiple lateral lymph nodes? So looking at the staging system post-operatively, as well as having that discussion with the surgeon and reading the operative report, are what will help guide me in terms of staging and figuring out the high versus low risk.
Yeah, it's really gone past just reading the path report and saying that's what the information is. We need all that information from the surgeons.